Hello, everyone. Mireille Weinberg. I'm chief editor at the magazine Capital. I invite you to take a seat, and we should start very quickly. We're talking about foregoing healthcare, which is a plague of our health system. To better talk about it, we have two main actors of the healthcare system. On my right, Bruno, who's the general director of AG2R La Mondiale. You're a graduate from Polytechnique. You're an engineer. You started your working in civil engineering, and you spent a bit of time in ministerial cabinets for transport, and then you had the very high position with McKinsey and Credit Suisse. You are now director of AG2R La Mondiale since May 2022. What is AG2R La Mondiale? It's a big group. You do social protection, patrimony, complementary retirement funds, healthcare, and with the healthcare package. And we also have life insurance with La Mondiale, and you also protect the assisted living and senior living. So you also have Mr. Sébastien PROTO, you're CEO of the Elsen Group, you're former director of the group Société Générale, and you have been for 7 years the managing director of Rothschild Bank. You have spent a lot of time within ministries with President Sarkozy. You have Sciences Po et Sakena as your diploma, and you have joined Elsan since September 2023. Elsan is a leader of private hospitalization in France. You have 28,000 employees, and you have many independent doctors who work in the group that is operating throughout France. You take 4.9 million people per year, and 2 French people out of 3 live less than 40 kilometers away from a Nelson house unit. So it could take different forms. We have 2 major actors. One, Mr. Angle, who's more in the financing side of the healthcare system, and Mr. PROTO is a supplier of healthcare. So why would we be foregoing healthcare? We're going to start with you, Mr. Angle. Between we enter the controversy, if we were to take stock of those foregoing of the healthcare, how do you see the future? Well, foregoing healthcare is, of course, everybody knows, is a phenomenon is getting bigger and bigger that has social impacts and societal impacts. According to a recent survey by the INSEE, the French national surveys, most people have said that they've foregone healthcare for the last year. So this is impacting the society, this is impacting the health of the French citizens, and this is also touching upon social and geographic inequalities. We have to wonder about the causes of foregoing healthcare. As often, the causes are many, and often we break down when we see all the causes that I'm going to identify. At the bottom of it, there are two reasons why foregoing healthcare. The one is the refusal. People refuse. They reject the care, either because they're afraid to go to the doctors or because they have philosophical or religious ideas. They don't want to be treated. So this is a matter of being educated to health. And then there's the barrier refusal, which is what we're talking about here, which is linked to structural causes, and in which we can make a difference between 3 main reasons. The first one is the delays to have an appointment that are very long. There's a complete gap between the need for healthcare to the provider, to the time when those healthcare is provided. So there's the rapidity dropped down by 8%. It's also a matter of geographical proximity, and this is getting worse as well. In the last 10 years, we have dropped by 4% the number of consultations that are available at less than 2 minutes of the house. It's the case in many regions, but even in the greater Paris region, if you want to see a dermatologist, you have to count a delay of 9 to 12 months. There's also a financial access to healthcare, which is another way of renouncing. And this is linked to the spending power of the people. If we look beyond all these causes and how the situation can evolve, we have a tendency to believe it's not going to get any better. Why? Because the renouncement, the foregoing due to difficulty of access geographically or delays are increasing because the demand for the medical care is increasing, but the offer is decreasing because we have less and less doctors, at least until 2030. And for the financial part, the financial access to medical care, we could see that it also went down because since 2022 was the worst year since the beginning of the law that was passed in 2013. So not only we have the conclusion that people are foregoing healthcare, and we know that this is going worse. Mr. Proto, do you agree with this assessment, and how do you see things moving? Do you think it's a complete disaster? It's going to be a complete disaster up to 2030? How do you see that playing out? Hello, everyone. I share a lot of the elements that Bruno Angle shared with you. There's the foregoing of healthcare, which means basically they give up. And there's also the delay in the medical care. And both topics are equally interesting. And the situation got worse in both cases. I don't want to go back to what Bruno said and the delay in getting care. If you talk about cancer, between the first consultation and the treatment, in the last 5 years, the average delay for a patient with cancer has increased by 2 weeks. 2 weeks when you have a cancer is huge. It's a lot of time. If I take the example of breast cancer, 60% of the women today have a breast cancer, and they are going between the first appointment and the treatment. They will not be in the delays that are recommended by science. So there's what is recommended, and there's a delay on it. And unfortunately, it is not aligned. Second topic on the situation in terms of foregoing healthcare and delay. It's not inevitable because some countries have lower rates of foregoing healthcare. If you compare us to the European average, in France, the average statistics is 6% of foregoing. In Germany, it's only 1%. Why? Because the medical supply is higher than in other places. Third, in the factors of foregoing, I agree with Bruno, and I want to raise the attention on two topics. This could be a chosen foregoing. Renouncement is something that I find very worrying. Is disinformation, particularly on social media. I take again the example of breast cancer. The screening has regressed in the last years. Why? Because when you go on social media, everybody's criticizing the mammographies. And a lot of women now stop doing mammographies, and it's a way of foregoing healthcare, medical care. And we have to fight this. And then we have the foregoing that is not chosen, that you are submitted to. So, for example, that's the economic factor, but I don't think it's the main reason. It's because in France, what remains to pay is very limited. But the other factors linked to the offer of doctors are the most important. The general organization of the system, and this situation is going to last at least until 2030. Again, nothing is inevitable. There are solutions, but for me, the main factor is the inequality of access to medical demography that has reverted in the last few years. And this is continue. 25% of the GPs are taking their going on retirement by 2030. It's a huge number to keep in mind. You talk about the fact that medical care is free, but it doesn't explain everything. How could we change? How could we do in terms of offer of medical cares to improve things? Well, But very quickly, renouncing, foregoing medical care is a deep subject of territorial, geographical inequalities within the French population. It has health impacts, it has creates inequalities, and also it has political impact. The incapacity to have a quick access to health is one of the political elements. Inequality in terms of access to medical care, you see it in the numbers. Bruno reminded us the delay to have an appointment. In some regions, it is way higher than in others. And what is interesting is to see that all the regions where the medical demography improved were regions where this demography was already good. All the regions where it went down are regions where it was already down, already bad. You have regions in which, for example, I take an example in Ariège, which is a small department in France. If you want to do a consultation in cardiology in Ariège, it's impossible. There are just no cardiologists in the Ariège department. And you have, if you want to see a cardiologist, you can have a delay for many, many months. So what do people do? In any event, the situation is going to last because a major mistake was made in the 90s with the fact that they closed the list of doctors graduating from medical school. There are solutions. I see two of them, which is I call city medicine. There are a number of things that need to be that we need to promote. The medical time is a precious time because it is scarce. So we need to accelerate sharing of tasks between doctors, between nurses. They don't have the same demography as well either in the years to come. The pharmacists, we made some progress, but we're not as good as in some other countries. Second, we need to develop the health care centers. What is it about? It's about grouping GPs and specialists in one place and taking more patients per hour than if they were each in their own office. 20% of the population only is covered by this healthcare center because the regulation does not promote it. This is the regulation is the authorization by the public authority to make those centers sustainable. Third, we need to encourage the private public cooperation in the hospitals. Private hospitals and public hospitals is often seen as a subject of opposition and conflict, and it should really be regulated as complementary. I give you a very simple example. We have a hospital in a city not very far from here where we have cardiologists. It's a new private group. The public hospital is nearby, and they don't have any more cardiologists. But the authorizations given are for the public hospitals, and the authorization that we have us in our group are very limited. So what authorizations are you referring to? To be able to have consultations in cardiology. So we have doctors who don't have all the authorizations, but the public hospital has all the authorization that they need, but they don't have any doctors. And so the delay to have, for example, an action on an aortic valve or something, a semi-invasive operation procedure, the average delay is 6 months. If they were to collaborate, would reduce the problem drastically. So we should encourage cooperations, and these cooperations are extremely difficult to put in place because the system today is not regulated to encourage them and to facilitate them. And I think that's one of the reasons, one of the ways we could address the problem. For the public, it seems crazy what you're mentioning in cardiology. We wonder how it's possible. Why aren't people thinking locally to try to regulate correctly the care? Well, maybe that will happen more and more as soon as the medical context is not going to be solved by itself. The demography is going to drop up until to 2030. So we have to collaborate and also to think differently. The system, it's an obligation. Otherwise, foregoing healthcare and delay in healthcare, I insist on the second part, will not reduce themselves. So the private sector should work with the public sector. In terms of financing the public sector, Mr. Angle, why do we see? I hear the insurers saying to the public, authorities, leave us a seat at the table. We can step in, we can help. I don't feel like you're being heard. I followed the sector of insurance with Echo, my magazine. It was already what we said at the time, and it hasn't changed in 20 years. What can be done? How can you really take the space that you needed to take, and what would you bring to the table? Complementary insurers. Well, if we have the copay that is quite low in France, like Sébastien PROTO said it's because we have complementary insurance companies, and they play a major role to reduce this foregoing healthcare for financial reasons, and because of the mutualization to allow those who have a complementary insurance, health insurance, to have access to medical care. Second element, yes, what was very well described by Sébastien on a form of absurdity between private and public hospital. We find it in the dialogue between Social Security and complementary organizations for healthcare. And you talked about having a seat at the table. It goes beyond that. We don't only need to be at the table. We need to put ourselves in a mindset where between Social Security and the complementary health insurance, we are on the same side of the table. We don't want to enter a dynamic where we have to negotiate as if we're on reimbursement. Is it up to the Social Security? Is it up to the healthcare package, additional package? Because you know that we always ask the additional insurers to pay more. They don't have. You have to be at the break-even point, right? Yeah, exactly. So it's the same for La Mondiale. If you don't have any shareholders to pay to, still, if you want to be in a situation where you're going to still be around in 5, 10, 50 years to bring your services, you have to have a balanced budget. And if we're being asked to pay more and more and to reimburse more and more, we don't have any other solution than to raise the membership fees. So that could be a problem because people will not want to have private insurance or complementary insurance because they won't be able to afford it. So I made a few calls to the public authorities to say, let's stop, throwing each other the ball. Let's sit on the same side of the table and work together. There's enough people, intelligent people, with the Social Security and with the complementary insurance organization. Let's work on prevention. Let's work to make sure that we ensure sustainable reimbursement. But unfortunately, this call has not been heard so far, and the quick turnaround of the ministers of health doesn't help. We've had 3 ministers in a few years. Mr. Gros, who put in place a dialogue committee with the complementary insurance. But the person who came after him, Aurélien Rousseau, only convened this committee twice, and it didn't go very well. And Frédéric Valtou didn't stay long to have time to do anything, to even convene it once. So it's not because we haven't succeeded so far that we should be giving up. I'm always an optimist. We're going to have a new Minister of Health, and we should try to convince him to get into this dynamic. Mr. Proto, you were talking about medical time. We have a problem with medical demography. We need to make sure that medical time is real medical time. We have the first Macron government suppressed, stopped with this list to have a certain number of doctors. But what do we do in the meantime to have things moving along?
Well, you chain the shares between what a doctor does, what a nurse does, what a midwife does. Nurses are playing an increasingly important role. They're coordinating and managing chronic diseases. We're comparing with foreign countries, and the comparisons can go further. There are lots of subjects that are difficult, but given the context of shortage, there are huge consequences. So, talking about these consequences, there are 2 that I would like to remind you of. First of all, You know, when it's difficult to access a GP or a specialist, but especially a GP, you go to the emergency wards. And so that means that you're creating a bottleneck. In the different groups that we have in different areas, there are no more GPs, and you might have an elderly population. The immediate reflex is to go to the emergency ward, and emergency wards are not made for this. The second drawback, given the medical shortages that we have, is that this delays the switch towards a more preventive-based system. When it's difficult to see your doctor, how can you possibly be part of a prevention care path? Now, there are two consequences. We have to adapt. The first consequence is that the overall system is sidestepping opportunities. There was somebody who showed that if we had the same performance for 10 indicators as the best centers, we would gain in terms of life expectancy, and the social protection system would save thousands, millions of euros. The second point, when you have this, think about the medical context, the population. Companies need to be developed as prevention centers. We spend a lot of time in companies. We've got technology, we've got digital technology, and so a company could become a place of prevention. This would enable diagnosis, screening, vaccination, and that would help with the medical shortage. It's one of the solutions. Now, you both know that in our healthcare system, every year, we've got the PLFSS, so the project for the social security system, and that does reshuffle the cards every year. Shouldn't we, you were talking about cancer early on, but this is almost what works best in France. Since the Chirac scheme, these are things that are not decided year after year, but on a more long-term basis. Shouldn't we have laws, multi-annual laws for health, just like we have for public finance, so that we can have something that's more durable? Both of you, this question is for both of you. Well, I think, let me go quickly. There's a French paradox. Health is a tendon sector. You have to have visibility, you have to have regulation in the medium term. And the big mistakes in the healthcare sector have been made because the short term has been the focus since the 90s. There's a multi-annual programming law for the defense sector, and it's the subject of a very broad consensus. There's no multi-annual consensus for the healthcare system. Now, when you want to make investments over time for the benefits of patients, you've got to understand how the economic mechanisms are treated with, for example, inflation. You have to keep in mind that the motorway organizations take into account inflation. Hospitals, clinics don't have this, and this seems the kind of system that needs to be reviewed. Yes, I agree, because it's a subject that I'm familiar with because of what I do. With the multi-annual law, yes, I agree. And I think there's a paradox between having a 5-year military programming and an annual debate, which doesn't really lead to many consequences. You vote, but the real expenditure for health is off target with respect to what was voted on every year. And there's another aspect that needs to be underlined. Although we have the best performance when it comes to cancer treatment, but we're not good when it comes to prevention. Far from that. And so we need to balance things out again. And this is probably better if we had multiple year spanning programming. Yes, I understand what you're both saying. You're talking about prevention as something that's very important. Can we also talk about technologies? That's something that can help us get over this population problem. Listen, yes, but technology, it's not going to save us. It can help us, but there's a condition for this, and that is that the regulation needs to follow the time it takes for technology to be developed. If you are going through chemotherapy, there are remote monitoring possibilities that allow you to stay at home but be monitored through remote monitoring devices that follow all of your constant values and that tell the medical team how you're doing without you having to go to a hospital. This is good for isolated patients. So this remote monitoring system has existed for several years now, and it was defined only 12 months ago as part of the regulation framework. But we have to be careful. Innovation must not gallop ahead of itself because you've got status quo innovation as well, and innovation offers considerable potential only if regulation follows suit, and that's not the case. Let me answer differently, but I think we will converge. We mustn't wager on technology alone. Technology is obviously important, but we need to think about responsibility too. When I say responsibility, it's the responsibility of all people involved. The challenges are so high because they're huge and they're important for all French people that we can only provide answers if all stakeholders are mobilized, whether we're talking about the state or the social security system as such, or additional health insurance players, whether we're talking about patients as well. When I say patients, I'm talking about, no, not just cuts and bruises patients, although they do add pressure. I think doctors also have a responsibility. My doctor in the Ile-de-Ré, and I don't blame him for this, he's 35, and he consults 6 half-days a week. He was trained by people who, when they calculated the numerous clauses, they imagined that he would be working 10 half-days a week. So that creates pressure. So collectively, we're facing a problem that's huge. And if we want to solve that problem, once again, we have to go beyond technologies or financing laws. We have to make everybody responsible. And it's only by making everybody responsible that we can get over the problem. Thank you. That was Mr. Angler. That was a great conclusion. It was all very interesting. Thank you.